All right, is everybody okay? So you know which button to press for your microphone? It's the big button with the person speaking on that's the microphone, okay? All right. Okay. Well, I'll apologise now because I do have cold. Okay, so my patience isn't what it should be. So I'll apologise now. Okay. For those that know me of old. For those that don't know me, don't worry. Okay, all right. Okay, good morning and welcome to the Calderdale and Kirklees Joint Health Scrutiny Committee. I think if we introduce ourselves first, Councillor Hutchinson.
Councillor Colin Hutchinson from Calderdale.
Councillor Joe Lawson from Kirklees.
Councillor Jane Ryler from Kirklees, Home Valley South.
And I'm Councillor Liz Mage from Kirklees. We've a couple of apologies from Councillors Robinson, Blackburn and Evans, we believe as well. Okay, so moving on to the agenda then. Minutes of the previous meeting. The minutes are in the papers. Do we approve the minutes as a true record? Yes? Yeah, okay, thank you. In those minutes, there are two letters at the end of the minutes. These were the letter we agreed to send to Mid Yorkshire because they were unable to attend our meeting last time, and the reply that we were sent from Mid Yorkshire with their apology for not being present and the information that we requested. Okay, so those are tabled there for the committee. They were circulated, I believe, at the time. Okay, are there any declarations of interest? Mr. Lawson.
Thank you. Just to let you know that I hold a bank contract with CHFT.
Thank you. All items are in public and this meeting is being webcast. We've no deputations or petitions and we've no public questions that have been notified. So we move to item 7, which is page 17 of your papers, and this is the maternity services item. So I believe we've got Calderdale and Huddersfield and Mid Yorkshire represented here today. So do you want to speak to your paper, please? Thank you.
So I want to take the paper as read, but sorry, apologies. Gemma Pocket, Director of Midwifery at CHFT.
Kerry Reedfield, Director of Midwifery at Mid Yorks.
We take the paper as read for Calderdale and Huddersfield. I particularly wanted to highlight our recruitment position, which has changed over the last few committees that I've attended in a positive way, and we have reduced our vacancy from a peak of around 30% in August 2023, currently standing around 10%, and anticipating by the summer that will have reduced further to around 6% with some additional recruitment, then with an opportunity to recruit again from the cohort of midwives due to qualify in September again. That does lead us to a slightly different risk in our workforce around the skill mix with a large cohort of newly qualified midwives, but we're managing that with a robust preceptorship package and support for those staff to build and develop them in their early career and continue to improve our retention of staff. Our Calderdale Birth Centre is now robustly opening 24/7, fully staffed, and moved away from the responsive model we had put in place, and that has seen a good increase in birth rate at the birth centre at Calderdale. And as discussed at the last committee, we have arranged a review for the Huddersfield Birth Centre, which will take place towards the end of April, to review the ongoing suspension of labour care there. Hand over to Kerry.
So with regards to Mid Yorks, we're now at full establishment for our staffing at Mid Yorks. Experiencing similar challenges because obviously the replacement staff that have come into post are newly qualified. So the challenges of orientating and making sure competencies to get them to have the experience to work in all areas of maternity services. Since the last meeting, we have commenced a consultation on the opposite side of the Wakefield area of our footprint. That went out live mid-February, slightly delayed. It was anticipated to go live in December last year. So that's a 12-week consultation. I think aligned to the ongoing actions with regarding to that birth centre, we had the soft launch of Bronte in birth centre, which is in Dewsbury on the 1st of April last year. Because of that, we've made the decision not to do a formal review 12 months in because of the soft launch of the service, and we're going to put that till autumn, so that will be around September. We'll be 18 months in. We'll be doing a full review of our provision at Dewsbury. It's currently fully staffed, and the only time, well, it hasn't been closed, the only time we would anticipate as part of our escalation process is if the full maternity service went onto a closure position because of capacity across the whole patch, because we need to maintain that. But I'm pleased to say that that has never been an issue, and we're able to support at all times to keep the Dewsbury site open.
Thank you. Can I just ask just 2 questions before I open it up for questions, please? We heard previously that Dewsbury Birth Centre had a soft launch, yes, but then it was going to be more widely publicised. So could you let us know if you have done that wide publicity before you're going to do the review?
So that is ongoing.
Right.
Those measures, when I came into post in the autumn, started. Obviously, there was some sensitivity with the consultation starting as well, but unfortunately that was pushed a bit later, so that has kind of delayed things. But it hasn't impacted on the measures with an action plan that has board oversight to increase the promotion for that birth centre.
Okay. And for Huddersfield, a review. Now, we keep hearing this. We're going to have a review in April, we're going to have a review in October, we're going to have a review in April. And we keep having that. And I appreciate you need to review your staffing situation. But realistically, is it likely that Huddersfield will have a birth centre open within the next 3 years? Or is it more realistic that you will promote the Dewsbury Birth Centre and the Calderdale Birth Centre as the alternatives?
I think some of that 3 years is a short time, but a long time in the terms of midwifery staffing. Whilst we're recruiting currently, we know there is an impending midwifery staffing shortage likely due to the very reduced numbers of midwifery applications that were received through the UCAS process last year. So we are anticipating we're going to enter a difficult period for being able to maintain and grow our workforce in a couple of years' time. So I think in 3 years, I think what we will have achieved is the review taking place in April is considering the demographic of the population, the complexity of the population, and therefore how many women are truly eligible for a low-risk birth centre, because the criteria is very strict. The likelihood of it reopening will depend on those numbers. It will depend on being able to retain and ensure that we've got everybody through their preceptorship package in the next 18 months, because it is a 12 to 18 month package that we have to have in place. Being a freestanding birth centre, we need to make sure we've got the right skilled staff with the right experience there. That is critical to it being able to reopen. So I'd like to say yes. We're at the minute utilising the birth centre for a community midwifery hub now, and have moved our community midwives into that space to enable it to run antenatal and postnatal care, and are just doing some estates work to facilitate that. So I hesitate to say yes, I definitely think it'll be open in the next 3 years. As a midwife and as the head director midwifery, I'd like to think we could get to that place. But I think it'll very much depend on both staffing, but I think we have to consider the complexity of the population as well as to whether we've got a viable service.
I think that on a scale of 1 to 5, with 1 being highly unlikely I think it's nearer the 1 than the 5 then, from your answer.
I think it's really difficult to say for definite, and I don't want to commit to something that either doesn't come true and in the end, or the opposite happens.
I appreciate that. It's just that we keep going round in this circle, and we need a definitive answer at some point in time. I'll open it up for questions. Councillor Lawson.
Thank you. We've heard on a number of occasions about the recruitment problems at CHFT. Is it more that you can attract the newly qualified midwives, but you can't actually retain them? And if so, what package have you got in place, other than, say, the preceptorship package that you've got people up to the skill thing? What other things are you actually doing to try and recruit, to retain staff that have actually got the skills and the knowledge, etc., and stopping them from actually going elsewhere?
So the recruitment challenges have been in a background of a national shortage of midwives. The pool has been small and the demand has been high across all organisations. And granted, CHFT have been slightly behind some of the other organisations. But I can confirm in 2022 and 2023 we retained 100% of our newly qualified midwives through their preceptorship package. So we have good retention and we have reduced the leaver rate of our experienced midwives as well. And we've done that through a variety of mechanisms. The preceptorship package is not just about competency, it's about wellbeing support, it's about pastoral care, it's about development, it's about encouragement. So that's all wrapped up in that preceptorship package. It's not just a tick box exercise. We have our professional midwifery advocate model, we have compassionate leadership, and that's been highlighted in our recent assurance visit through the LMNS. So all of those things contribute, as we know, to a workforce that wants to stay and develop. Last year we approved, I think it was circa £20,000 worth of CPD opportunities for our existing staff. All of those things contribute to staff wanting to work at CHFT. We've been into the university again and have a good indication that we have around another 19 students who are wanting to come and work at CHFT when they qualify for September. So we are working hard to make it the place to be and nurture and develop those midwives to be our future.
Thank you. If I could go on to another question, is can you actually tell me where you do the antenatal classes for both of the trusts?
So we deliver an antenatal class package, formal classes run by our public health team. They're delivered at Calderdale Royal currently. We do have one-to-one antenatal information education that's given. The benefit of us being back in the birth centre at Huddersfield is we can utilise that space and look to run some information there. And we're just currently working and developing relationships with some of our community partners to look at how we can go out and deliver some antenatal education in alternative locations, particularly trying to reach some of the women we find it harder to hear the voices of. So we're looking at the model that Woking have, where they go into the local mosque and deliver some antenatal education. We've identified some women's groups we can attend, and we're looking at perhaps wider antenatal education for multi-generational support of pregnant women as well. So lots of plans, but currently the main package of the formal group classes is at Calderdale Royal, but looking to expand that.
It's good to hear that you've actually got any plans, but when is that likely to actually happen? Because obviously you have got women that are falling through the net, the women that probably maybe need the actual classes and maybe the actual support from others. And it would be good, as you rightly say, to take it back to a more community-based model so that people, it could be their local mosque, it could be their local community centre, because obviously they then meet other mums or mums-to-be, and you've then got the basis of the friendship. But to me, is at the moment, it just seems that if you're from Huddersfield and this side, that a lot of people are not going to go to Calderdale.
Appreciate that, and I think that's why we're keen to do that. That is one of our top priority actions for this coming financial year. We've looked at our most impactful actions to improve outcomes, and that is one of them. So we're just looking for estate space and community space that we can go into to deliver that. We're also listening to the women and what they're telling us about how they like to access information, and that isn't necessarily coming to face-to-face group sessions. So we're looking to utilise social media better, different aspects of social media to deliver some of that education, and virtual options.
Yorkshire want to come in on that today.
So similarly, we use our birth centre to provide our parent education. And obviously what we realised on the back of that COVID period that, you know, one delivery model doesn't fit all. So as much as doing it as a face-to-face, weekends, we undertake evening sessions as well as utilising social media to put it across. Because quite often we're seeing that we're reaching the converted and not necessarily the wider footprint. And that's where we're doing a lot of co-production work with our MNVP chairs as well to see how we can get out there. I suppose the challenge to that is, you know, we've been asked to come out of some of our GP surgeries and things like that, so it's finding that estate out in the communities to regularly be able to plan and schedule those things. So at the minute, it's more productive having it within the maternity estate.
Thank you.
Thank you. Well, I can think of a few community settings in North Kirklees. Councillor Ryler.
Yeah, good morning. Yeah, just a question, broad questions really about recruitment and retention. And you do get some recruitment from international countries and apprenticeships and shortened midwife programs, and I'm just wondering what the proportion is for each of those in terms of recruitments. And also, are there enough places at universities for all the students who would like to train to be midwives? And why are the number of recruitments, I'm asking a slightly different question, the recruitments are dropping then as well? It's not as popular a profession as it used to be, and I'm wondering why this is the case then as well. So a number of things. Apologies.
I suppose to start with, we know that maternity services is very much in the social media, and it is on the national agenda as well, so that does have an impact. It must do. I think historically we've had issues with funding for programmes as well. We had a period where if you wanted to be a midwife, you had to pay for your training. So all those play an impact. I know Mid-Yorks, we've got a large proportion of international midwives, but from a previous provider, you know, it's not always straightforward, and that training overseas doesn't mirror. There's lots of things that make it able to support, but that journey from preceptorship once they join the organisation has been quite protracted from our experience. So there's a finite number of that, and obviously there was costs involved and funding to support that. I can't think what other point I was going to make. Yes, sorry, apologies.
Asking about places, why people are not taking up, and what's the retention, why the retention is going down.
Yeah, and I think what we have been very good is recognising that we've got an ageing workforce and seeing how we can fill those gaps. But when we're looking at apprenticeships, that's backfilling that, and it's quite a lengthy journey for a less qualified member of our team to undertake that journey. And I think one of my personal anxieties has been, because of that, there is a likelihood of needing to step off during that programme and not seeing it to its entirety. You know, we could be talking, 4 years for some of our colleagues to reach the end goal, and that's a long period of time when there is no guarantee. So I think, as well as looking at all opportunities out there, has been the introduction, well, not the introduction, the post-RN registrants, and ensuring that we can get those back into our numbers as an alternative. So already registrants, nurses within the footprint, then to do the extra 18-month to 2-year programme. So I don't think we're staying static. We're very much looking at that eclectic approach and not putting all eggs in one basket to get where we need to be, but recognising that it's not seen as a career maybe as it was historically.
I think student retention is something that the LMNS, the local maternity neonatal system, have got a work stream around, because what we know across the whole of the LMNS is that retention rate of students we've had something like a 30% dropout rate from commencing the course to completion. It's very high, and we need to understand that better. Is that we're not recruiting perhaps the right people into the career pathway that they thought, it's not what they thought it would be. So working with the universities to be part of that recruitment process again, so that we can have that joint conversation around what midwifery is like as a career. I think absolutely the national picture around maternity and the scrutiny, the messaging is off-putting for people to come into the career. The shortened programme is great that it's available now, and the apprenticeship, and I've come from an organisation prior to moving back to Yorkshire that we were very involved in the apprenticeship and put some of the first on, and I'm very keen that we develop that as a mode of growing our workforce. However, the backfill, you can't backfill in the same way, so you release people, and it is a fine balance between increasing your vacancy essentially because you haven't got those people working for you while they train, versus having enough workforce on the floor, to support and develop them in their student, to help retain them through that. So it's a fine balance at the minute. At CHFT, we're working on a 5-year recruitment strategy now, revisiting some of this about what we need to do. International recruitment has been fantastic. We have got some internationally educated midwives. The process is quite long. It's not a quick fix, and nor should it be, and it isn't comparable in terms of the countries you recruit from. However, we have to be careful not to deplete those countries as well, and I think given the level of international recruitment there's been across the UK, that is now the danger, is that those midwives and those countries are now feeling the effects of that recruitment. So it's a very fine balance to be had between building and growing your workforce. We've definitely got a drive to recruit and grow our local workforce, because those are the people who live here. They use our services as families. We want them to be invested and work in them. So our focus is really now on growing our local community to develop midwifery pathways, and some of that is going into schools, talking about midwifery as a career pathway, and catching people as they're young before they've really maybe made a decision about where they want to go.
Okay, all right, okay. Girls Lodge.
Thank you. The figures that you've given from UCAS, a third reduction in the applicants for midwifery courses since 2021, those are national figures. How much are they reflected in the local figures at the University of Huddersfield? Is it more or less popular in Huddersfield than nationally, or is it about the same?
I don't have the local data that I can break down for you here, but I can get that and find out from Huddersfield what that data is. We do take from a couple of different universities, so we tend to look across the patch, but I can certainly find that information out exactly for you.
And as you say, the national media stories about the sorrows of various midwifery units around the UK are not the best setting to encourage people to go into the profession, maybe. Is there any scope for pitching a different image locally? Is that something that you're doing, or is it too risky a strategy?
Well, just to say, the LMNS has undertaken a video that incorporates all the providers within the LMNS as a promotion of maternity services as a route and a career pathway. I think the other things that we're doing to support our students is joined up recruitment as well. So we historically used to see a lot of attrition because everybody would accept a post, and a soon-to-be newly qualified midwife would accept multiple to make sure, because obviously a first choice might not be the first interview that she was successful in. So I think that joined up approach is making sure we've got our new graduates in the right place, makes them more likely to stay put and not want to move. I think the other thing that we're doing as well, Mid-Yorks as an organisation are very pro flexible working, right from joining the organisation, and that's something now we're exploring with students during that 3-year period that they're with us as well, to see how we can support that work-life balance, meet expectations.
Looking back 40 or 50 years ago, doing a stint, training and doing a stint in midwifery was a very common part of registered general nurses' careers. And some of them stayed in it long term, and some of them did it for a while and then went on to working in other areas. You have referred to that as being not such a popular or well-trodden route nowadays. I know there's problems with recruiting to nursing posts across the board, but do you feel that there's any measures that you can take to make that a spell of midwifery training and potentially working in it long term? Is there any scope for making that a more popular choice?
So the post-RN positions are limited. There is not as many universities providing that programme. And obviously there is the backfill to, whilst that training is ongoing. There's also quite high attrition in that route because they already have a registrant qualification to fall back on, because it is a very in-depth programme. They still need to meet the same number of competencies from number of births, etc., that a midwife undertaking a 3-year programme would be. So we do see quite a lot of attrition from that. The benefits from that, it's at a different time of year that we're getting new graduates into the organisation, so that's a positive. And you've got very experienced nurses that have got the nursing qualification and the midwifery one. So it's absolutely something that we would support more of, but I think our hands can be quite tied in number of places to undertake that.
If the universities are struggling to fill their places for undergraduate midwives, is there scope locally for them increasing the number of places for the post-RN training? Is that something that is actively being looked at?
So we've worked with the University of Bradford to offer the post-RN conversion course. I think there are some elements in terms of you have to have a certain level of degree qualification to undertake the course in the first place, and that's where we came to a bit of a stumbling block, because the RNs who were interested didn't have that required level of degree, and were therefore required to either do further study first or not progress that. So I think there are plenty of places. I think there was funding available to support the post-RN qualification. People are making financial decisions about whether they can afford to perhaps leave a paid job to undertake a further graduate degree. I think that impacts. In terms of your previous questions around how we advertise maternity as the place to work, I think some of the key to that is starting early in schools. I think some of it is we can always do more locally. It is bearing in mind the sensitivities of the national picture and the terrible experiences families have had across the UK with some of the inquests and inquiries that are ongoing, and not getting the balance right between saying this is a wonderful place to work and it's a really joyful career versus we really acknowledge some terrible things that have happened in maternity services over the year. So we tread that lightly, but we have had that LMNS-wide approach to trying to advertise the career pathway. I think the post-RM one is one we should really pursue. And I think we should lobby nationally for support around. I think some of this falls out with just local hands, and we need to collectively lobby nationally to improve the funding position for training, because people are financially impacted currently with the cost of living, are less likely to make decisions to pursue a different career. I think in terms of the current nursing training, they don't routinely rotate into maternity. There is a lot they have to pack into their training as well, and trying to put maternity into that may not be feasible. We have recruited general nurses before to work in maternity, particularly through the COVID period. That has limited success because the career pathway is quite limited for them in midwifery in terms of being able to progress and develop without converting. So there are options. I think we need to really pursue for me, the apprenticeship and the post-grad training.
Okay, can Can I ask then about the necessity for provision? So at the moment, you need to provide different choices for women, so home births obviously, obstetric-led and standalone midwifery units. Now, at Calderdale, the midwifery unit is next door to the obstetric unit, isn't it? And the standalone in Kirklees is at Dewsbury. So, looking at the numbers that have been going into the Bronte Birth Centre, there's very few, in fact there's hardly any, from the Huddersfield area. And I'm wondering if people are being given the choice of the different birthing units, the obstetric unit, what are the, do you know what the considerations are in people choosing the Calderdale Birth Centre over the Dewsbury Birth Centre? I'm just concerned as to whether structures are getting in the way of choice. Yes.
So when we, Kerry shared the numbers of women based on postcode breakdown of who are accessing Bronte, I have asked our community matron to go away and do a piece of work to assure ourselves that we are discussing Bronte robustly as an option for women in Huddersfield particularly, as a birthing option, so that we can evidence either we need to do more work around that and continue to work together, or that we are offering it and women are choosing not to. I think we need to understand that first. I think women do get a degree of security from being in an alongside birth centre, knowing that the obstetric unit is close by for assistance should they require it. We do monitor our transfer rate closely, and mostly it's for pain relief or because of complications in labour, rather than we can't facilitate birth in the birth centre. So I think we need to also keep an eye on that. We regularly discuss the birthing options when we meet with our MMVP chair and when we hold the sessions with the women who use our services about discussing the options for birth choices. But I think we need to assure ourselves that that robust discussion about all four options is taking place, particularly for the Huddersfield women currently. So that's underway.
Thank you. I think we'd be interested to know what the outcome of that is, as to what choices are being made and for what reasons, so we can understand the full picture. I think that would be helpful to us. But also there's the Ockenden review, isn't there, etc., and all the work that's being done around maternity at the moment. Are you expecting any changes in requirements to workforce to come through as part of any... I know it's difficult, you can't say what recommendations are coming through, but are there any indications that changes in increases, say, in workforce are going to be needed as a result of any reviews?
I suppose we always have to be mindful from a training perspective, because there's a large proportion of maternity training that is mandated nationally. And you know, we do have an increased uplift within our established to mandate for that. However, you know, should there be significant ask of different types of training, which is always a likelihood from an independent review, then obviously that would be a further detrimental effect on staffing numbers. And from our organisation, I know it would involve a business case then to go forward. I mean, we're in a very lucky position that we meet birth rate plus as it stands at the minute from a staffing perspective, but there is always the potential that there might be a need for increased staff.
I think with the reviews, what's become clear is the workforce models in maternity haven't always been sufficient to meet the acuity and complexity of the women who are using the services. I think a good example of that, and featuring in the national HSIB reports, etc., is particularly around the maternity assessment centre and that triage process, and the volume of women that are seen there and the complexity of that area certainly has changed our workforce demand. I think enhanced continuity care, and that's certainly in our next 2 years, our priority is to roll out enhanced continuity of care teams for our most vulnerable. That will require additional investment in workforce to achieve that. And so we have that in our planning process to do that over the next 2 years. Recruiting to that will then be the challenge that we also face in terms of how midwives want to work and how much flexibility they want within their working life and demand on their personal time to be flexible. So I think those are the two challenges in the next 2 years. I think the Ockenden review at Nottingham may produce some additional reviews, but I suspect the bulk of it will be to say that what has been recommended before is still what is required. But I think as the complexity of women change and the demographic of women having babies continues to get more complex, I think that workforce demand will change and increase, plus the additional training requirements that go alongside with that.
Yeah, thank you. Are there any other questions, Catherine?
Can I ask you, this is 4.2, the responsive model. And it states that in July 2023, staff were deployed to other clinical areas, which sounds, I've never heard this before, when no women were in labour. But when they weren't using that responsive model, then, well, the birth rate per month was 8.75, July 2023. But then when they went back to the 24/7 model, then it was much, much higher. So were women going somewhere else to have babies during that time? And where might they be going if that was the case?
So the responsive model was in response to the staffing challenges we had in the vacancy rate, so that we didn't have midwives who were in an area not working clinically, providing care to a woman whilst we were waiting for labourers to come in. So they were redeployed to other areas such as labour ward to support that with the vacancy that we had. The difficulty we then had was that they would often then be allocated women to care for on the labour ward, and we couldn't release them back to the birth centre. And that related to our large vacancy rate. So as soon as we've had the opportunity to retract from that responsive model so that we can robustly staff the birth centre and be available in there 24/7, that's why the birth rate has increased in there. So women were then being redeployed because essentially we were consolidating our intrapartum care to the labour ward because we had to maintain safe staffing levels and we weren't able to release the staff back to the birth centre. So the theory was good, applying it in practice was much harder than anticipated.
So, just to clarify then, so you have the Calderdale Birthing Centre, but you haven't been able to fully staff it at times because of the need to cover, for safety, to cover the obstetric-led unit. So, in actual fact, therefore, the choice has been obstetric-led unit only for a period of time because of the requirements to staff the labour ward, yeah?
So through COVID, the national advice was that where staffing challenges were significant, that we should consolidate our intrapartum care to one area. That will be the labour ward because you have to be able to care for the obstetrically led women as well. That is exactly what we did. The closure, the responsive model and then the inability to offer choice of Calderdale Birth Centre was intermittent because we didn't want to do a full shutdown of that option if we could possibly help it, hence trying to be responsive with the staffing model for it. So it was intermittent, which would sometimes be part of a shift or it'd sometimes be whole shifts or a couple of days. We do have to report that every 2 weeks into the national programme, and we have been doing since about 2020 across all organisations. We did work with women who we got very mixed views about whether they would have preferred to know it was not available at all and that we did a block suspension of the service, or whether we opened it as soon as and when we could. And we got very mixed feedback around what the right thing to do was. So we tried to be responsive to that by having the model where we would not have people sitting in there, not doing anything, because that sounds terrible, but not caring for somebody directly versus being utilised in another clinical area during the vacancy. So that was in line with national advice, but yes, limited choice for women, which is something we recognised as a risk.
Yes, I just can't understand why Mid Yorkshire has been able to sustain a birthing centre, granted just for a short period of time at this moment in time, but CHFT has not been able to fully staff both a birthing centre and an obstetric centre. Mid Yorkshire, do you want to clarify your position?
Yeah, so that's because we've prioritised the staffing in our freestanding birthing centre. So with every unit being fully established, you would still have a need on occasion to escalate, and part of that escalation when activity goes beyond the mean and average, and part of that escalation would be to look at your other staff in different areas and how you can utilise them to best effect, because obviously safety being the priority. But to highlight, when you've got an alongside birth centre, that has been to the detriment of our Pinderfields birth centre, because we've had to utilise those staff if nobody's been in there. So it is a very similar picture. We've made the decision for the freestanding one that has that core staff there, and because it's not co-located, and the anxiety of not having that messaging out there, if we had to close that birth centre, you'd have an unsafe position of somebody potentially turning up in labour at Bronte. So we do experience sometimes that there is no activity, clinical activity taking place, but obviously from a safety position, that has to be the case. But we do relocate from our co-located birth centre.
Thanks. I was wondering from this discussion whether the responsive model had any impact on the ability to have home births, whether the staffing levels influenced that area of choice and service.
That's run by a separate rota, so from our perspective, it doesn't impact on the home birth option.
So through the period we've had over the last few years with the vacancy rate we have had impact on being able to sustain the Calderdale Birth Centre robustly 24/7. Obviously, they suspended the Huddersfield Birth Centre, and on occasion that has impacted on our ability to support home birth, where we've been in periods of escalation due to staff shortages, and we have had to call those community midwives in to support, again, consolidating that intrapartum care. That, again, is in line with national requirements. We have to prioritise safe care in labour, where we have to have 2 midwives at a home birth, so we haven't always been able to facilitate that with the vacancy that we'd had at CHFT. So we are very aware and very much recognise the risk of the birth choice reduction that we'd had during that period, but that is much more robustly being offered now. I think the important bit to remember is vacancy is one bit of it. We also then have mat leave on top, which could be anything up to 10% of our staff plus short-term sickness. So our vacancy fill on each shift could be quite large at times due to a combination of all of those things. So we have been impacted, and we have taken the measures we've needed to take to ensure safety of care through the intrapartum period.
Ursula Lawson.
Thank you. Do you feel that midwifery has become somewhat medicalised within sort of CHFT? And is that a reason why staff are actually leaving, that you've got the retention problem? Because obviously most midwives want to be able to be there to care for women giving in birth. If you've just got the option of an obstetric unit, no experience on standalone birthing units, home births, etc., is that one of the reasons why they're actually leaving?
So just to clarify, I'd like to say we don't have a retention problem. We've had improved retention, say retained 100% of our newly qualified midwives over 2022-2023. The last cohort is still in their preceptorship period. So our retention is good of midwifery staff currently. So I just want to be clear on that. Midwives deliver a wide variety of care. It's not just about birth. And they care for women across the whole entire pathway from conception through to discharge into our health visitor services and back into primary care primarily. And not all midwives like to care for intrapartum episodes of care. So the important bit is that we are offering choice to our midwives. They all rotate. Generally, we have some core staff in each area, and the rest rotate to ensure we maintain a good skill mix and that we develop our newly qualifieds. So I think the reduction in birth choices has certainly impacted on morale of the staff at time. What we haven't had is an exodus of staff leaving for another birth centre job and role, because most organisations operate in the same way that we've operated.
Thank you. Moving back to the Bronte Birth Centre, are you able to tell us how many is, obviously with most women, when they choose somewhere to to give birth. They want to make sure that it's safe, fundamentally safe. Obviously, can you actually just tell us how women are assessed as to being, yep, you should be okay to come here, and what is the actual transfer rate?
So, as part of maternity care, there is a risk assessment that's undertaken, and each point of contact that would be reviewed, that they were on the right pathway of care and that their birth choice is still appropriate. So from that understanding, they would know, and they can change at any point in time. There is that choice element. We do have our birth choices clinic as well, our new personalised care booklet, which supports that decision making. So it's ongoing. It's not just spoken about at the start of the pregnancy continuum. It's all the way through that journey. So there is an awareness of what is out there. We have our regular carousel events as well, which promote speaking to staff from all areas to have those conversations. And to be honest, people, that is a concern that we hear, you know, what about our transfer rates? But it's getting that message across in a balanced view. You know, if you need somebody to make an informed decision, they've got to know the positives and potentially the negatives, should there be any. But I think as specialists in maternity care and in normal maternity care, I think that's what our core midwives in the birth centres are aware of. When there is a need to transfer, things aren't at a stage where it is unsafe because if they've preempted that, you know, they need an extra level of monitoring, for example, something like that. So a decision is always made timely. And I think through Parentcraft, through the open door policy we have to the birth centres to come for walk rounds and the carousel events, there is that opportunity to share that narrative so people are aware of the options for them to move. I don't have the actual numbers, I think, printed in there, but I can certainly share them outside of this meeting, the most up-to-date transfer rates for you.
Thank you for that. One of the reasons why I asked that question was obviously when you're trying to sort of sell something that's a bit new, a bit scary for sort of mums to be, it's good to know that there is all of this happening to actually reassure people.
Okay, thanks. If you could let us have that information, please, because your graphs are your births are April to January, and your graph that has admission, transfer and birth activity is April to December. So if you could let us have that up-to-date information, please. Okay, are there any further questions? I wonder, do we want an item to come again to committee, bearing in mind that CHFT are again undertaking a review and that they've been in what you call a responsive mode, shall I say, for periods of time. I think Mid-Yorkshire have also, but you've prioritised the birthing centre, haven't you, if you've needed to take staff from the Pinderfields Birth Centre. But do we want this item to come again after there's been the review of the Bronte Centre and the review that CHFT are undertaking? What do the committee feel? Yes, yeah. Okay, all right. I think it would be good if you could, because I'm concerned that we just seem to be going around in the same circle, if you see what I mean. I understand, especially when you may need more staff in as a result of other reviews, etc. So I think there needs to be a bit more certainty around how we're moving forward. I think that would be what I would say. Councillor Hutchinson.
Do you think it would be worth including outcomes within that rather than just the numbers of births and procedures, because obviously that's a fairly crucial element to the quality of the service.
Okay, so what I've got then is you're going to let us have the education and dropout rate information that's more local to ourselves. You've got a review that's happening Mid-Yorkshire have got the review of the Bronte Centre that's happening. We talked about workforce pressures, etc. You're going to have you're having a review of choices at CHFT, what choices are being made, and what information is being given, and why people are making the choices they are that we'd be interested in. And you're going to let us have an up-to-date transfer rate as well at Mid-Yorkshire. Have I missed anything there? No. Okay, all right. Okay, thank you ever so much for your time. I think we'll just pause the meeting for a minute while we just rearrange seating and I can have a drink. Thank you. Okay, we will restart the meeting then, and we move to item 8, which is the update on the hospital reconfiguration programme. I wonder if you've obviously received your slide pack. Are you going to talk to that at all? If you could introduce yourselves as you speak, please. Anna, are you starting? Thank you.
Hello, my name is Anna Basford. I'm Deputy Chief Executive and Director of Transformation at Calderdale and Huddersfield Foundation Trust. And as you say, we've provided ahead of the meeting a slide pack which provides specific updates against the topics that you've requested that we update you on progress on today. I've brought, as you see, there's a number of colleagues working across a number of areas of our programme of reconfiguration who will be able to speak to the various topics and answer questions on. We're also very happy to actually walk through the slides and present them to you, but we'll take your advice on whether that's appropriate or not, or if not, we'll be happy to go directly to questions. Thank you.
Anybody want any clarity on the question? I'd like clarity on the target operating models slide. You lost me halfway down that one. If you could go through that, that would be very helpful. Thank you.
Yeah, good morning, everyone. I'm Rob Aitchison, Deputy Chief Executive at CHFT. Yeah, thank you for that. I think it's helpful. I guess in terms of why we presented these today, these aren't necessarily kind of patient-facing, public-facing slides at the moment around the target operating models, hence your comment. What we wanted to do is show you a little bit of what's under the kind of the bonnet, really, the engine of the work that we're doing. So the target operating models are effectively the model of care that we're aiming towards. A lot of it will be consistent with what we're doing at the moment, the types of care we're providing. I guess the key difference really is around how we'll configure our services in the future as part of the reconfiguration, which we've talked to you a number of times about. And effectively, it is those kind of set of guiding principles. The way we're using them in the organisation, it's a really great kind of language to use with teams. It's a really good model to use to develop services to make sure that we're being consistent with how we'll be configured in the future. I would say there's quite a lot of innovation within there as well around different models of care that we'll be developing over the next 3, 4, 5 years. And as you can see, I think in terms of how we structured them, it isn't necessarily language that you'd probably traditionally recognise, probably barring Councillor Hutchinson in his previous clinical role, but we've structured them in a way that isn't too detailed, but in a way that would recognise the kind of main different streams of care and types of patients that would come through the organisation. So if we talk about planned care and theatres, that is predominantly around people who are coming on an elective pathway, a planned kind of operating pathway. Whereas if you jump down to kind of medical non-elective, those are those patients that will be accessing care in an emergency situation. So it's proving a really helpful tool, really great engagement across the organisation. I think what I probably would say is as we head through these next kind of 3 and 4 years further into the reconfig kind of journey, we'll talk to you in a lot more detail about these. But for now, it was just really to point at how we're doing some of this work. And I've included a couple of kind of screenshots of kind of 3 or 4 of those in the pack as well. They weren't intended to be read. It was more just to see the format and how we're using these in the organisation. Thank you.
I realise I'm probably me being a bit this morning, but so you've got 2 sides of this to the project. You've got your build side, and then you've got your service reconfiguration. Obviously, your service reconfiguration dependent on your build side, because you need your build side to be completed before you can do your service reconfiguration. Yeah. So you're talking about your clinical strategy for 24-29. So is this clinical strategy in place at this moment in time, or is it something that is fluid over the next few years as to how you're going to operate the reconfiguration? Are you keeping services where you initially said they were going to be put? Is this just about how you're going to move those services and what sort of service people can expect from the newly reconfigured service? So how will we know, how will we have a measure of outcome from a newly reconfigured service that that can be measured to say this is a significant improvement, or this service was good as it was and that hasn't changed? How are we going to understand that, and how are we going to understand your journey of reconfiguration and how that's impacting on services? Okay.
So I'll start by addressing that question, and I'm sure both Rob and probably Dr. Davies will want to come in as well on that question. So the first part of your question about our approach to reconfiguration, we remain consistent with the location of services across the two sites that we formally consulted on. So the first part of reconfiguration is to get services co-located in an appropriate way that will improve the delivery of care by them not being split across dual site, which requires movement of both patients and colleagues. So that is unchanged. But what we do see, as you quite rightly say, is the ability to reconfigure our services is reliant upon the provision of new accommodation. And that new accommodation itself provides a catalyst for change. It provides an improved environment for patient care and for colleagues to work, which enables them to work in new and more effective and efficient ways. We also recognise with the passage of time there's constant change in technology, the application of digital technology, and also new drugs. And there's, again, increased and changing expectations from members of the public about how they wish to access care. So we've always been consistent about where services will be located, and that in itself will bring a number of benefits to quality and safety of care. But we're also very keen that this provides a catalyst on this journey to really make sure that we're harnessing the latest technology and really transforming our services. And that's what the target operating models are about. So they are fluid because they will take account of changes that may happen in innovation and technology between now and the end of the reconfiguration programme. But they are, as Rob's described, a concise way to describe what members of the public should expect from these core pathways of care about how they access services, how that service is delivered, how they're communicated with. And there's a programme of work currently engaging with colleagues and using feedback from patients and engaging with patients to develop those on that journey. So, hand over if Rob or Mark would like to come in and add to that.
Yeah, morning, I'm Dr. Davis. I'm an A&E consultant and clinical lead for reconfiguration and transformation at the Trust. Councillor Smidge, I think I'd go one further. You mentioned there's two elements. There's the build, there's the reconfiguration, which is more about where we do the things that we do. But then there's the transformation, and that's changing the way that we do. And I think these target operating models are more about changing the way that we deliver care. How do we do it in a more efficient, this more patient-centred way? And the reconfiguration and the building works, in some respects, are an enabler for that to happen. So, for example, if you were to take the medical non-elective pathway, so these are people who need the services of our acute medical teams, we're looking at a model whereby if a GP or the ambulance service or anybody in the community feels somebody needs the medical team, then they can send them directly to the medical team. They don't necessarily need to go through the emergency department. However, at the moment, our medical teams are split on both sides, and they can't provide that access 24/7 like we'd like to on both sides. So they need to be all on one site, so that they got that sort of accumulation of the staff and the savings of efficiency of scale. But in order for that to happen, we have to reconfigure our services, which means we need extra wards over at Calderdale to be able to accommodate them. So the building work allows all of our acute medical team to be on one site, which then allows us to deliver the TOM that we want to deliver, which is better for patients all round.
Your 25, 26 milestones, you're talking about your multi-storey car park work starting, your enabling works for your clinical building, and your maternity floor works beginning. So do we take it therefore, because we've asked previously about the go-ahead from the Treasury. Do we take it, therefore, that you have had that go-ahead and it is now all systems go? Because you're talking about your full business case. And I know we've had this discussion many times, outline business case, full business case. But do we take it that you've had the approvals on your outline business case and now you need to move to the full business case, and that in itself needs to go back to Treasury?
It is correct that we have full support to progress to develop the full business case. Based on our outline business case submission, we're being encouraged to develop the full business case at the earliest opportunity, which is what we're doing, and progressing through the milestones as you indicated.
That has to go back to Treasury for that full business.
Each business case requires formal approval, so the full business case will require the final stage of Treasury approval.
So my question then, on top of that then, is it took quite a while to get your outline business case through Treasury. Are you hopeful that your full business case will be in the go through Treasury in the time periods that you need in order to meet your timescales to be fully reconfigured by 2029?
Good morning, I'm Stuart Barham, Deputy Director of Finance. Yes, we are encouraged by the dialogue we've been having with Department of Health on their timelines for approval of our business case, and that obviously links into Treasury. There's indicative timelines in their guidance that's several months, and the support that we've received in the dialogue we've had suggests that they will shorten that to support our timelines. We've reflected those timelines within the slide pack that you've received today, so again, encouraged by that dialogue.
One more and then I'll on now. So, the changes to structures on a national level, is there a clear pathway through for you still, because it'll be with Treasury presumably that you will be talking with this business case, or are there and the Integrated Care Board obviously for West Yorkshire. So is there clear structures moving forward to enable you to keep going with the process?
My answer to that would be yes. We're aware that there have been a number of national announcements in the past week. We continue to have the right connection and dialogue.
I just wanted that reassurance that you were having those conversations and that you had the pathways. That was okay. Right, I'll open it up for questions. Councillor Hutchinson.
Thank you. Obviously, we're coming out the other side of winter, which various parts of the country, various organisations have struggled. The impressions we get is that CHFT has withstood that much better than many others, but it has required a lot of additional beds being opened to be able to keep that level of flow through the hospital system. I'm not clear whether those additional beds have been mainly on the Huddersfield site or on the Calderdale site, and what that experience is telling you about the modelling for services coming out the other side of reconfiguration. But I mean, am I correct in saying that although it's been quite hard work and services have undergone stress, we haven't had the corridor care that's been going on in other parts of the country?
Yeah, thank you. So I would agree with your assessment. So it has been a tough winter. I think our teams again have gone over and above across in all areas. But what I would say in response directly to your question, no, we haven't seen those levels of corridor care, and I think we've got really clear kind of ways in which we manage capacity within the hospital. So I would say we haven't seen that level of care in the hospital. What I would say in terms of your question around the kind of the growth question, in the work that we've done leading us up to the full reconfiguration, growth was assumed within that. So absolutely, what we're seeing at the moment, I would say, is at slightly higher levels, particularly around the kind of winter activity. But that growth isn't unusual, and it's factored into the model of care that we've got and the configuration on the Calderdale and Huddersfield site. So we'll continue to refine those growth assumptions, and we'll continue to plan to have that capacity within the hospital in the reconfiguration model. What I would say is we have to keep having an eye to alternative models of care, though. So as Dr. Davis said earlier, things like your same-day emergency care, admission avoidance, the role of community, they're really, really crucial because in the NHS, you're always going to see growth. And if you assume that that's just going to be in beds, you're never going to have enough space to put people. So we're on track with what we said we would do. And we'll continue to challenge ourselves around how we kind of make sure people are in the most appropriate place to receive their care.
Similarly, this has been the first winter that the new Huddersfield A&E has been open, and the experiences that you've gone through there, I'm interested to see that you feel that some of the nationally defined space from in various parts of the building, which were designed to the hospital technical memorandum standards, you felt that the way they've functioned has been impaired to an extent by too much space, that's going to be reflected in the design of the A&E department in Calderdale. Could you say a little bit more about sort of which areas you feel those space allocations were too generous, or whether it was that you felt that increased space in another adjacent area would be better, the space would be better used if it was divided up in a different way?
Yeah, so I think that the size isn't detrimental to function. I think it's probably bigger than it needs to be. In particular, the cubicles that we manage patients in the emergency department, the assessment cubicles, they're big, and they're probably bigger than they need to be. And in the design of the new department at Calderdale, we've decided to make them a little bit smaller, but added an extra couple. So it's repurposing the space, rather than making them all as big as they are at Calderdale. At Huddersfield, we make them a little bit smaller, and the staff are confident they can still deliver the care to a really high standard in those rooms. At the same time, it's not mentioned in the slide, but the ambulance assessment cubicles we've got at Huddersfield are probably a little bit smaller than we'd like. So they're going to be a little bit bigger at Calderdale. So it's tweaks. There's no cavernous spaces that we don't need, but it's tweaks and recognising that a hospital technical memorandum that was written a few years ago is great in principle, but there's a balance to be had in everything.
In the new clinical build, instead of having wards, it's largely single room accommodation. Have there been any the thinking of how to actually supervise people who are ill within single rooms has always been a concern? How there's different parts of the country, different hospitals where that supervision is facilitated in different ways. Has your line of thinking changed at all in how that's going to take place at Calderdale Royal?
So yeah, in the new wards over at Calderdale, there'll be 28 beds, 16 of which will be single side rooms, and we recognise that there is an increased need for visualising those patients and supervision and observation. So we are refining the nursing workforce model for those wards. It'll be different to the standard that we've got currently of a 24-bedded ward, which is mostly bays, 4-bedded bays. So there will be a refinement of that workforce model. At the same time, we've reduced the number of wards that we're going to have compared to what we originally planned to have. So that's been taken into account. So we were originally we were thinking of 10 wards of 24 beds. We're now on 8 wards of 28. So there's a movement of the nursing workforce within that without an overall increase that we were expecting. The other things that we've done in the design of the single bedrooms, the original design was to have effectively the bed head at the opposite side of the room to the door. And through the design process we've had to date, we've been able to use what's called an immersive suite, which is a digital innovation for design, where effectively they can project the room onto the floor in sort of full-size dimensions, and we've been able to push effectively a trolley into the room or a bed into the room and actually see what the visibility would be like. And as a result of that, we've now reversed that room so that the head of the bed will be immediately inside the door. So we've redesigned that room based on that technology so that we can now see that if you're walking down a corridor, you can see that you've got a very good view of that patient in that room. So that improves the visibility and the supervision from a design concept. So as well as the staffing model, it's designed to improve visibility. So we don't lose that, like you say, there's a lot of benefits of having single rooms in terms of privacy, dignity, infection control, but there is that observation and supervision element which isn't quite as good as a 4-bedded bay. But we've taken mitigation to that, both from a workforce and a design. So we've designed some of that out.
Because I believe that there are hospitals where there's camera monitoring of patients, not so that you see the real person, but an avatar of the person, to be able to say whether they're in their bed, whether they're on the floor, whether they're moving, whether they're not moving. Is that kind of technology something that you see a place for within the new design?
So we haven't gone as far as cameras in the room, but we are looking at digital falls mats and there's now digital beds, so that if a patient gets out of the bed, a nurse is alerted to say that Mrs. Smith has got out of the bed, rather than waiting for Mrs. Smith to fall and then get an alert. So we're looking at other technical and digital advances, but we haven't gone so far as cameras into rooms, because in some respects, unless you've got that avatar and those safeguards, there's a whole can of worms that could be opened. So we're going for a halfway house.
Yeah. Can I just ask, on your maternity floor slide, which I noticed your construction will commence summer and take approximately 9 months. You say that you plan to develop a bereavement suite with the support of the hospital's charity. How far are you along with that planning? Because I think that is something that, really should be in the plans, definitely, rather than there are also plans to.
Yeah, so I would just clarify, it's probably how it's worded on there. So we have a bereavement suite. We've been working to respond to some recommendations around where that's situated from a kind of a dignity and a kind of from a patient perspective. So we have one in place. We're looking to improve it and make it even better. So those two pieces of work will be happening alongside each other.
That's fine, because I think it was the way that it was worded.
That's fair.
And I think
Absolutely.
Why would you not have one? Okay. All right. Councillor Ryler.
Thank you. Dr. Davis, you were talking about changing the way in which we deliver care, making it more efficient, making sure that the staff that are needed are on the one site. And presumably, does that mean that there will be different clinical areas in the different hospitals? So does that mean that there will be some clinical areas that will be in Calderdale and others that will be in Huddersfield? Yeah. And with the new build in Calderdale, will that mean that there will be more clinical areas in Calderdale compared to Huddersfield?
Yes, so the clinical model that we're working to is that all non-elective care, so all unplanned care happens at Calderdale, and there'll be a planned care centre at Huddersfield, as well as the Accident and Emergency Department that's there now. So overall, there'll be a net movement of inpatients. Most of our inpatients are non-elective, they're unplanned. So there's a net movement of those to Calderdale, which is why we're building the extra 200 or so beds over there. The vast majority of our planned elective inpatient work or planned work for surgery and things, the very short length of stay, so we don't need that many beds. There'll be lots of patients going through that service at Huddersfield, but they won't need to stay in beds so many.
Yeah. That makes sense. Thank you.
Okay. Can I ask about your refurbishment work at HRI? Because I can remember sitting here and being told it was a long list of things that needed to be carried out, and though it was going to cost an awful lot of money in order to do those things at HRI. You've got a list of key investment and longer term development plans. Can I ask then, do you have the funding in place for all of these longer term development plans? Do you have any timelines? And what is continued site rationalisation involving, please?
Okay, thank you. So, as outlined on slide 49 of the pack is some of the key investments we've made over the last few years in the site. So, obviously the new A&E you've been aware of. We've done a number of other developments that the site's had significant investment in. The next slide shows some of the other key areas that we need to do to address the backlog maintenance. So you'll recall that within our outline business case we had £95 million worth of backlog maintenance. Some of the schemes that are listed on here will address some of that backlog maintenance. So ward refurbishment programs and theatre refurbishments are things that we need to do. From a timeline perspective, some of the works will continue to be done today and over the next few years up to the point of reconfiguration. Some of that work will need to be done post-reconfiguration as it gives us capacity to close a ward, move out the patient staff off that ward, relocate them, whilst we give it a strip out and address some of that. So things like window replacement, we can't replace a window whilst this patient's on the ward, and the same for the refurbishment. In relation to the funding for that, so that will be addressed through our normal capital resource. So the trust gets around £20 million per annum for investment into its medical equipment, its IT, its estate, and we will prioritise some of that as we have done over the last few years to continue to invest in that. And you may have also seen that there are often national priority pots of capital that comes out and gets announced, and we've been successful in the past at receiving some of that. So the ward refurbishment that we did on Ward 18 was funded through a national pot, and we will take the opportunity to maximise that investment. The site rationalisation point that you specifically asked about talks to the point that Dr Davies referenced before, where more of our inpatient activity will be delivered, all of our inpatient activity for non-elective will be delivered at Calderdale, and therefore we will have a smaller requirement for a bed base at Huddersfield, and that's where we will seek to rationalise so that we can minimise the estate structure, and that by not using the estate we can limit the investment we need to do into the areas that we'll do and focus our investment.
Okay, so do you have an up-to-date site layout of where your thinking is as of now, as to how the layout on the HRI site will work going forward, or is that something that is going to be further down the line or part of your full business case, or where is that thinking at this moment in time? Because I seem to remember there was things wrong with concrete and things like this and cladding and stuff like this. So how is that moving forward, and what will the site layout look like in the future?
So I'll take that one and I may draw Robin, if I may, on in that response. So we're working through the design for Huddersfield at the minute. There's some indicative areas where we know that there's better estate, i.e. we've got less backlog maintenance in those areas, and the intention is that we maximise those and focus our investment in those going forward. There's a link into the TOMs that we talked on, the target operated models we talked on before, about how do we make sure that we know what services are being delivered on that site, and know where we're delivering from, and we can effectively flex our estate to get that investment over the next few years. So there's been a lot of thinking gone into it. It's not a finalised model at the minute, as we continue to look at what that demand looks like, what that model looks like.
Yeah, and I would just add to what Stuart said there. So clearly a lot of that thinking will be based around those fixed assets that we have at the moment. So clearly our theatres are a really key part of what happens on that site in future. To answer your question, I think we're somewhere in the middle of that work. So we have a working set of assumptions that we're continuing to refine. Clearly we need to get there in the next year or two to be really clear around what it's going to look like longer term. Clearly, we've got some great assets on that site. So those of you that have visited kind of Acre Mill outpatients, it's a great asset, and it's something we'd want to continue promoting in the future. But the most of the work will focus around that main Huddersfield site.
Okay, it's just that obviously with the acute site having the work, then the planned site work, you know, having more of an idea of what the planned site work will look like, I think that's important for us, because I realise it will be a longer time frame for that work, because you've got to get the acute side ready first. But I think it is important for us to know what the planned site, HRI, is going to look like in future. Okay, all right.
I think we're very conscious of that, both the acute site over at Calderdale and the planned site here, but also particularly for our colleagues who are going to be working in the new build at Calderdale and the existing build at Calderdale. We're not planning on having a poor relation or anything like that. You know, we're all one big team, and we all need to see the benefits that we're doing here.
And people who are using your services need to see the benefits as well. I think that's where I'm coming from as well. Councillor Hutchinson.
It's not been mentioned, but it has been a feature in quite a number of trusts around the country that elective surgical hubs have been set up in partnership with or totally provided by private sector partners. And I just wanted clarification that that isn't in the mix of the way in which you intended services to be provided going forwards.
I can confirm that is not the case, or is the case, depending on which way we take it. But no, we have no intention of entering into a private arrangement. I would probably say, just for clarity as well, we have an elective surgical hub at Huddersfield, which is really well recognised, and it kind of one of the trailblazers. The elective element of what we do, you know, to Mark's point previously, it's really, really crucial. So, you know, any potential that Huddersfield could be a poor relation in this, I think absolutely not, because of the fact that we're prioritising that elective work. So, no, there isn't any intention at all.
Thank you for that clarity. Regarding the carbon, you know, there's an NHS net zero plan that we're supposed to be working within, and obviously you talk about the use of modern methods of construction for the new build on the Calderdale site as being contributing to that, and as well as contributing to reduction in noise and dust for people, you know, in what is a fairly densely residential area. Are you working to a carbon budget for the overall construction phase, but then the operational phase of the programme? And in terms of modern methods of construction, how easy is it proving to actually source the prefabricated sections locally? Because we get conflicting messages about how experienced and the ability for modern methods of construction to be used more widely across West Yorkshire.
So thank you. I'll take that question. Our cost plan for the programme includes the allowance for BREEAM Excellent that we're aiming for, but also the use of modern method construction, but also the net carbon zero technologies in there. So we're moving into what is called REBA Stage 4 at the minute, which is the technical design of all the kit and infrastructure that will make the hospital operate, the air handling units, etc. And all of that is based on a net carbon zero target to align to the current NHS standards. And that's embedded within our overall cost envelope for the building. And then when we go forward, that technology is often more efficient than the current gas boiler, for example. So we'll hopefully see financial benefit as we move forward and reconfigure and make the most of that efficient technology. The second point to your question was around the modern methods of construction, and I think it's Doncaster, but someone else will correct me. But workshop close. So we went for a visit as well. So Lango Rock, who are a design partner, own a manufacturing unit in Worksop that develops the panels, effectively, that the construction of the building will be made from. So that's where we've got the sourced, and we've got that guaranteed chain, supply chain, because the construction partner owns the facility that develops that. And that will be used, and the design of what they've described is that technology will be used. It will be built off-site, transported to site, held very briefly, lifted directly off the wagon onto the site, and that again comes back to that modern benefits of modern method construction. And it will limit the impact on the local environment for the local residents, for the disruption to the site as we develop that, because they're very conscious that it's a live environment for a hospital, but also accessible by patients, visitors and Scott residents around the area.
Just one quickie about the multi-storey car park. The enabling works, I presume, have been done through the winter. When is the do you have a clear idea as to when we'll start to see something rising from the ground on that site?
So we're well progressed with the enabling works, as you say. I think we're anticipating a likelihood of seeing something rising out of the ground during this summer. And our experience on other builds is once it starts coming out of the ground, it's pretty quick.
Councillor Lawson.
Thank you, Chair. I note that both outpatient services will be provided at both sites. Obviously, outpatients has probably got the highest amount of attenders for people. Will there be duplication in clinics? Say, for instance, ophthalmology has the eye clinic at Acre Mill and at Calderdale. And I'm assuming if you're basing all the medical stuff at the outpatients for clinics for medical things will all go there?
No, just all we're centralising our inpatient bed base on that workforce, but we will have medical and surgical clinics across both sites. Yeah, we'll be sharing them across both sites. There'll be some services as outpatients that we'll only deliver on one site because of specialist equipment and things like that. But I'm not anticipating any major shift. You'll have to go over there to see a medic or over here to see a surgeon or anything like that. No.
Thank you. That is actually really good to know, because obviously when you've got patients, say, living in Todmorden having to come to HRI, or somebody who lives in Shelley having to go to Halifax, it does, and especially with elderly patients, it's really good to know that there will still be clinics at either site, so that there should be some patient choice.
Yes. And the same with diagnostics as well as providing them in the community diagnostic centres, then they'll be provided on both sides.
Okay, can we just touch on the full business case, please? and how we can scrutinise what's in your full business case. So, understanding that contractually there are confidential contractual areas within the full business case. So, on your slide you've got review any minor changes and implications. I think we'd like to know about any of those. Your value for money, confirm financial implications and financing, but ensuring successful delivery, i.e. a comprehensive delivery plan, and I think that would be something that we would want to know about as well. So how can we move forward with scrutinising your business case as it is developed?
I think that's something we'd like to have further discussion about. So in relation to previous business cases, we have been able to provide information of a non-commercial nature to ensure that panel members are informed and assured around the content of those business cases, that they are in keeping with our public consultation and previous discussions around what our aims and intent are. There will be commercial aspects of that, but I think for those aspects that are not commercial in nature, we would welcome a conversation which we've been able to do informally in the past with panel members. There is always the case that as we produce the full business case, it is a draft document, and therefore until it is approved by Treasury, has no formal standing, so is also not a suitable public document. So I want to be clear of that. It will not be a public document at that stage, but we have worked for a long time to support a full openness with scrutiny and would wish to continue to do that.
Yeah, we can have those discussions as to how we can do that. Okay, thank you. And during this process as well, because people are going to see a lot of change going forward, more change than they have had previously, even with the new emergency department, HRI, there's going to be more physical change in buildings. How are you going to be reassuring people who are using your services or visiting your services about how things are moving forward and what's going to be expected, etc.? How are you communicating across both areas?
Thank you. Fran Hewitt, Assistant Director of the Reconfiguration Programme. We've actually been doing quite a lot of work on our communications, involvement and experience elements of the programme. We've got an involvement and experience plan in place, and we also now have a communication strategy which ensures that we can keep people informed and also engage them at the right times. Our most recent developments have included launching a residence alert system. So that has been communicated by mail drop to houses in HX1, 2 and 3 to raise awareness of that opportunity for people to sign up. And that is a subscription service whereby we will provide updates to people, particularly hyperlocal news that may affect people, such as if we're expecting increased construction traffic to site or temporary increase in noise or dust as a result of what local work. So from a very practical level, that is that kind of facility that we've provided. On the broader side of things, we're doing some work at the moment developing our website. So colleagues have been involved in creating a map of the future, if you like, which will describe very clearly to people which services will be configured where on the site at Calderdale. And that will help people to understand how all of the different pieces of work that we're working on are interfacing with one another. In addition to that, we have been providing much more of a regular drumbeat of news and information to people, including our own colleagues, around updates on each of the projects as things like timelines and contracts and things have been agreed with contractors, so that people feel more informed and that they understand how they can get information and what's coming around the corner. We're continuing with some of our well-established communication routes as well. So we have a quarterly stakeholder briefing that goes to partners. We also have regular meetings in the diaries. We have meetings with our local ward councillors as well to update on important matters. And the latest piece of information that we've shared with local residents is the update on our reserved matters application for the new clinical building. So local residents received a mail drop just a couple of weeks ago, and we updated ward councillors through a briefing. So we're continuing our work. We have an email address for the reconfiguration programme, and we're using that to ensure that if people want to contact us with suggestions or questions, that they can do that as well.
I can confirm that the engagement with local ward councillors has been very, very well received. I did wonder, following the mail drop about the reserved matters application, whether you've had many emails or contacts from those residents who've received the mail drop.
No, we haven't actually received any feedback from residents on that, but I'm hoping that people will take the opportunity to visit the planning portal.
Presumably, when works are happening in HRI, then you'll be doing the same approach for people in Lindley as well. Yes.
Yes, and we did do that during the build of the new A&E with specific communication with the nearest neighbours in particular.
Thank you. Are there any further questions? No. Okay. Thank you ever so much for coming. I think we close the meeting there before I lose my voice entirely. Okay. Thank you ever so much, everybody, for being here today. Thank you.